who is our state health chair for the Tennessee State Conference NAACP. Tanae, it's in your hands.
Thank you, Daphne Nelson. I do appreciate the introduction. So today we are in for a treat. I know if you're here to get more information about what we can do to protect our community and our family and ourselves from COVID. And if individuals do happen to contract COVID, what can we do to make sure that they're taken care of? So we have two experts here to talk to us, and I'm going to spend a little bit of time on their introductions, but I really want to make sure that we hear from them and then allow you to interact with them directly. First, we have Dr. Alcindor, who is a PhD. He's the Associate Professor in at the Center for AIDS, Health Disparities Research, Division of Microbiology and Immunology, Physiology, and Obstetrics and Gynecology at Meharry Medical College. He formerly served as a special government employee for the FDA and also served as a consultant to the FDA Antiviral Drugs Advisory, which is now the Antimicrobial Advisory Committee. Dr. Alcindor is also a member of the expert advisory panel for the American Lung Association COVID-19 Action Initiative. He currently serves as a professor, adjunct professor, Department of Pathology, Microbiology and Immunology, Division of Infectious Diseases at Vanderbilt University Medical Center. And Dr. Alcindor received his postgraduate degree at the NIH and Johns Hopkins University Program in Molecular Biology and Viral Oncology, respectively, and went on to graduate school at the University of California at Davis. And we also have my colleague on the Board of Health, Dr. Calvin Smith, who's a native of Atlanta, but now resides in Tennessee, in Nashville, Tennessee. Dr. Smith received his medical degree from Meharry Medical College and trained in Nashville at Meharry's Internal Medicine residency. He holds faculty appointments at Meharry and also has a clinic serving the greater Nashville community at Nashville General Hospital. He serves as the clerkship director for the internal medicine rotation for third-year medical students, and he's also assistant dean for admissions and chair of the admissions committee at Meharry. He proudly serves as a physician member of the Nashville Board of Health. So let's go ahead and get started with our presentations. You're also going to hear from President Gloria Sweetlove. And so between these three presentations, hopefully that will give us a wonderful foundation for us to have a conversation on the other side. So Dr. Alcindor, I'll go ahead and turn it over to you.
Dr. Alcindor, please unmute yourself.
So thank you for having me today. I'd like to thank the organizers for inviting me to be on this webinar. I want to say that this is part of the Pass It On trial that I'm going to talk about today. This is a national trial. There are two sites in Tennessee, and they're both here in Nashville at Vanderbilt University and at Meharry Medical College. Both are participating in this Pass It On trial. And the idea is that you're going to pass on a component of your immune system in the form of a soluble factor called antibodies that are contained within the plasma fraction of the blood. And that component would protect you from infection by neutralizing the coronavirus. So again, this is a fraction of the blood that carries antibodies that can neutralize the virus, and of course can do two things possibly. And again, this trial is to evaluate if this convalescent plasma, as it's called, can neutralize and keep people from having severe disease and keeping them out of the hospital or reducing hospital stays. Next slide, please. And so this is a nationwide campaign. It's a nationwide study to evaluate convalescent plasma. Because as we know right now, convalescent plasma has received emergency use authorization since October 23rd, 2020. However, it is still being evaluated to see if it is going to be a useful intervention to treat COVID-19 patients. And so it comes from the blood of patients who have recovered from COVID-19. These patients develop these antibodies, and antibodies are proteins that can actually bind to the receptors of virus and prevent those viruses from initiating the infection. And of course, this is used to help fight the virus if it's given to people that have acute disease and are in the hospital. So convalescent plasma is not a vaccine. It is a treatment option for people who become sick with COVID-19, and the trial is designed to evaluate if this is a viable treatment option. Next slide, please. And so who can join? Anybody that's eligible, up to 1,000 adults who are hospitalized with COVID-19 currently at a participating location. And to my right, maybe to your left, you can see the different trial sites throughout the United States. And of course, there are 25 locations across the US, 2 hospitals in Tennessee, and that is Meharry Medical College and Vanderbilt University Medical Center. So what happens after joining? After you join, a study participant would receive 1 dose, about 250 milliliters of either convalescent plasma or a placebo. Remember, this standardized method to evaluate a drug for its effectiveness is a prospective study that is going to be randomized and be placebo controlled to see if that drug is going to be effective at treating a person for a particular illness. And so participants are monitored while in the hospital after receiving this bolus of plasma. And of course, that information is passed on to the study team. And of course, these individuals will receive compensations for their follow-up. Next slide. And so why is this study important? COVID-19 infections and hospitalizations are still on the rise, and we're still seeing about 60,000 new infections every day. And of course, people are still dying of COVID-19. So there are some states like Michigan where hospitalization rates are through the roof and are at critical stages right now. Treatments to help fight COVID-19 are desperately needed. This would be another option to treat patients. And of course, 1 cycle of this convalescent plasma could help potentially multiple patients at the same time. Some communities are more at risk for becoming sick, and so convalescent plasma in this trial is targeted to those underserved communities that are more at risk for severe COVID-19 disease. That includes African Americans that are nearly 3 times more likely to be hospitalized and 2 times more likely to die of this virus. And of course, because underserved populations represent essential workers, these are groups that are most affected by social and health inequities, and people with underlying health conditions are going to be more at risk for severe complications. Next slide. And so it is very important that this particular trial targets those people that need it most. And these are underserved minorities. They make up of the 917 current enrollees. And we only need about 83 more to complete this trial. Over 40% of the trial participants are racial and ethnic minorities. Next slide. And so it is very important that the information that comes out of this trial is going to be shared with participants at a level that they understand. So sharing in this study results in an important part, making sure the research results are communicated to people who can benefit from the findings. And of course, this will be done in the form of town halls, webinars like we have today, newsletters, infographics, radio, video, and so forth. Next slide. And so there are many ways to share and support this trial. And that is, you can share information with other people you know that have recently been diagnosed with COVID-19 and have been hospitalized. They could become potential participants in this trial. Those individuals that don't know about Pass It On trial, please give them this information. They can visit the website, and that is the passitonstudy.org. They can follow this trial on social media, and they can sign up for the newsletters and webinars that are going to be a part of the information exchange between participants, volunteers, and the public. Next slide. So anybody that wants to be a part of this study, wants more information about the Pass It On trial, you can contact the Pass It On trial team at the email that you see on the screen or at the website that you see below. Thank you, and I'll answer questions when appropriate.
Thank you, Dr. Alcindor. I do want to save our conversation for after all of the panelists have spoken, but I do just have a couple of questions I just want to make sure that that you address before we move on to the next speaker. You mentioned that convalescent plasma is a potential therapy for treating hospitalized COVID-19 patients. That I received. Now, and you also said that this is a study that randomizes to two arms or two different groups.
That is correct.
So one that receives convalescent plasma and one that does not. But right now, can you tell us what the standard of care is for patients that are hospitalized with COVID-19?
So the standard of care for patients with COVID-19 depends upon their condition when they come into the hospital. And so if you come into the hospital and you have oxygen tensions level that are relatively low, then it would suggest that you need immediate care. And after evaluation, if they do a CT scan on you and they see considerable lung involvement with opacity, and you are having difficulty trying to breathe, that individual may require mechanical ventilation. Of course, for those individuals that are going to give convalescent plasma, these are going to be people that have recovered from COVID-19, and after a certain time, they have enough antibodies in their system that can be utilized by way of a blood draw, and then the plasma would be separated from the whole blood. And now that plasma can be used in a person that has recently been hospitalized. And of course, at the early stages of infection, convalescent plasma would be more effective in those patients.
That's very helpful. And you might have said this before, but when it comes to research studies, I don't think we can ever ask too many questions.
Sure.
We know that convalescent plasma is a potential therapy. What studies or what observations have been done to let us know that even in this clinical trial that it's a safe application?
Yeah.
We're trying to see if it's effective, but will it harm someone?
So convalescent plasma has been used for many years. It stepped in the Ebola crisis and made a name for itself there. It stepped in for a number of infections where we had no antivirals or vaccines at the time. And the idea is that if you're trying to develop something immediately for an infectious disease where you have no developed antivirals and no vaccines, convalescent plasma is your best bet, and it has done this for many years. More than 70,000 people have received convalescent plasma since March of 2020. Convalescent plasma is considered relatively safe by the FDA because the FDA gave convalescent plasma emergency use authorization August 23rd, 2020. And for you to get emergency use authorization, it has to get through phase 3 clinical trials with the green light. It also has to get through the Data Safety Monitoring Board, as well as the FDA Advisory Board. And of course, the FDA Advisory Board gives a recommendation to the FDA for it to go on and to be analyzed by the CDC for indications of distribution and emergency use authorization. So it is critically scrutinized as any drug would be for its safety. And of course, this trial is to understand and examine its efficacy specifically for COVID-19.
Thank you. And then my last question before we move on to the next speaker could you talk a little bit about the race and ethnicity of those individuals participating in this particular clinical trial?
Yeah, so as the graphic showed, 40% of the participants, of the 917 participants, 40% of them are from ethnic diverse populations, particularly Black and brown communities in the Nashville area, in the Tennessee Nashville area. So again, all of the 25 clinical sites have taken on this same responsibility of diversity within their participant ranks. And so this is something that is across the board among all sites that are doing the Pass It On trial, is to include participants where there is representative members of minority communities that are actively participating. And again, we clearly understand that this has been problematic in the past, and everything has been done to make sure that the Pass It On trial does not repeat those types of activities that have happened in the past.
Thank you. I'm sure we'll have additional questions later on, but thank you for framing the conversation.
Sure.
Next, I'd like to introduce someone that needs no introduction. President Gloria Jean Sweetlove is here with us. And she's the type of person that can talk and has stories on end and can talk about any social justice issue. But today she's going to come here with us and talk a little bit about her perspective around COVID and the vaccine. President Sweetlove, I'll turn it over to you.
Thank you so much, Tanae, and thank you, Jackie. I have such an excellent health team in the state of Tennessee. I'm truly blessed by all the talent we have and how hard they work. Dr. Smith and Dr. Alcendo, thank you all so much for coming on. We have quite a few participants on, but this really needs to be bubbled over to everybody, everywhere. So I'm hoping that when Daphne gets it on YouTube and et cetera, we can send it out to churches and et cetera, because the information you're giving us is so critical. I want to talk about, as Tanae said, I'm a lifelong advocate. I mean, anything that's civil rights, social justice, I advocate for it. And I do that on a daily basis. So that runs me into a lot of people. So hopefully I'm able to share some information with them that can make a difference. COVID has touched us, and as it has almost some of everybody in very special ways. I had a very special, pretty young first cousin that passed away from it. He was a healthy man that had no pre-existing conditions and et cetera. We think he picked it up from the gym, and we thought he was doing okay. And hey, his brother talked to him and he seemed to be doing okay Wednesday. 3 o'clock Thursday morning, he checked out. And then one of my best friends, one of my brother's best friends, and one of my best friend's husband, and one of our church members, the entire family got it, and he left us. So I have some very, very personal, and then we've got a young woman's probably 45 from our church who is now in the hospital from COVID. So it really does strike home, and it's really so important that as people and as community leaders, that we step up and encourage people to be parts of trials, and encourage people to take the vaccine and to wear their masks. You know, I've got my little niece and nephew live with me. So if you see junk in the corner of my studies, because that's where they store their toys, and I can't move them every day, so that's where they are. But one is 2 and the other one just got 5. And one of the things they say before they leave the house is wear your mask, wash your hands, social distance. So they know that. So we've said that again and again, but now we are really blessed that now we have an opportunity to get a vaccine. And I have, most of you guys know, but my youngest son is a healthcare official. And one of the things he did, everybody said it was impossible, but I think I had my last flight February 29th of 2020. About the second week of March, he sent me a text and he said, "Mom, stay in the house." And that was funny. And, people had started, staying home and et cetera. And people were saying, "I can't believe you aren't going somewhere. I can't believe you aren't flying." And I said, "Well, now the son said, stay at home." And we have made sure that I think everywhere is cleaner than it's ever been. But at the same time, we want to continue to make sure that we wash our hands, that we clean areas, that we social distance, and that we always wear a mask. But as soon as the vaccine was made available, I went online to try to sign up. That didn't work. And so that Monday morning, my son has pre-existing health conditions. So I said, let me try to call and see if I can sign him up. So I called, I got a number, and I called, and they signed him up, said, give me the email. Before I got off the phone with them, they sent me a email that said he was signed up. I said, well, I hadn't heard from mine. Let me call back and sign up. And I did. Truly within about 3 days, we were called, had appointments, went and got our first shots, came back home with basically no problems. A month later, we went and got the second shot. D had no problems with his second shot. I had minor fatigue like problems that went away in 2 or 3 days. But we are encouraging everybody. It's when you think about this vaccine, it's not just for you, it's for others. Because we now all have vaccines, I was able to see my sons that live out of town, my grandbabies, and my daughter, everybody on Easter, and a first cousin, and we could sit down and have dinner because we were all vaccinated. I just watched something on news a few minutes ago, and the head of the CDC is now saying that, okay, if you've been vaccinated people can be together in small groups, and we can have a family time, and we can have dinner, and etc. So we're just encouraging everybody. We'll say again and again, the benefits far outweigh the little discomfort you had. I'll take any day, a couple of days of feeling a little bit fatigued, to knowing that if I get COVID, it doesn't say I won't get it, but if I get it, it will be a mild case. I probably won't be hospitalized, and I definitely won't die from it. We, even those of us that are really faith-based, we still don't want people to go. And when I think about it, I have to think about that the people go way too soon. So if there is something we can do, and what we can do is get vaccinated. And not only get vaccinated, but tell everybody in your family. You know how we tell everybody when something good happens? Excuse me. Well, this is something good. So we need to tell everybody in our family, all of our neighbors. I actually called up one of my neighbors, one of my little friends, because somebody had told me that she said that she wasn't going to get the vaccine. I called her up. I said, oh, wait, what is going on? You must get the vaccine. And she told me she had some apprehension and why she had it. And I talked her through that. And that's what we need to do. We don't need to just say, oh, well, they decided not to do it. This is about life or death. We don't know all the new strains that are coming probably every day. And the other thing is, if we don't get it, what if we pass it on to somebody and they get really sick? So it is so important. I can't stress enough as a leader. I want all of our folks, one of the things we do when we've got a big election coming, we said, arrive with 5. That means you go to the polls, take 5 folks with you. So I'm saying to all of us, go with 5. If somebody is nervous about going, go with them to make them comfortable so we can make sure that we get vaccinated. You all know for real that the most uninsured and most uninsured are people in our community. And a lot of times people don't know what they really need to know to protect themselves. This is why I wanted to have this panel, to make sure that we got the information so that we could share it with all of the people in the community that, hey, it's safe, it's important. And like I said, I got it. It's been more than a month since I got it. I am doing wonderful and well, and I want you to do it. Thank you all so much. Again, thanks to Tanae and Jackie for putting this together, and thank you, doctors, for being on.
Thank you, President Sweetlove. Just one question, and then of course we're going to open it up a little bit later on. I'm just curious, how many people a day, on average, do you talk to and encourage to get the vaccine?
Probably 40. Probably 40. I mean, everybody I talk to, I encourage them to get the vaccine. Everybody that I text or email, I encourage them to get the vaccine. Let me tell you this story and then I'll get off. I have first cousins in Ohio, and I call them brother cousins. They are my mother's only sisters, only sons, and I grew up with them. And I had gotten my vaccine, the first shot, and I called up and I was talking to them. I said, what about the vaccine y'all got? They said, well, no, they've been calling us, but I haven't got it. I said, oh, no, you got to get it. I said, Jason said, get it. That's my son that's in the medical profession. I said, he says we all need to get it. So not only did they go, and their 2 sons go and their daughter go, but I called the other cousin up and he went. So we got that whole family, 3 or 4 households of people vaccinated. So anybody I talk to, and I tell them, look at the science, don't listen to what Facebook says, go to the CDC website, pull it up. And, and I tell them, it's like any other vaccine, it's important. This one is saving our lives right now.
One thing that I've learned recently with regards to COVID is that any type of intervention, the vaccines, understanding more about therapeutics when individuals are sick, the best messengers are individuals that are in our immediate circles. So thank you for the example of talking about that. And now we do need to also start talking about convalescent plasma and that as a potential therapy in the research. So let's keep layering those messages.
Yes.
Jacqueline has put into the chat information about where to find vaccines, but also information about the Pass It On study, and also the same study at the clinicaltrials.gov link. So you can look for yourself and sort of become familiar with the clinical trials process and that information. But in order for us to be able to share it and pay it forward, we have to familiarize ourselves with it. So lastly, our last panel speaker is Dr. Calvin Smith. And Dr. Smith, I was introduced to as the person leading the COVID response for Meharry Medical College. We all know Dr. Hildreth, who's an infectious disease physician, but Dr. Hildreth can't do everything by himself. And so Dr. Calvin Smith is a trusted voice and a trusted face, and just very calm in his approach. And so Dr. Smith, I'm going to allow you to sort of set the stage with what do we know now, today, April 27th, about vaccines. What would you like our participants to know? And then we'll
Thank you so much, first of all, Ms. Franklin. I really appreciate you thinking of me, and I'm very honored to be here. President Sweetlove, it's going to be hard coming after you, but I'm going to do my very best to try to follow up. I really need you in my clinic to help me to send the message, because you got it on the nose. What do we know today about COVID and its variants and the vaccine. So the first things first is that the COVID, where we stand with COVID right now is on a pretty good precipice. We're getting really close to where we need to be. And people really need to understand that, especially in places like Michigan and other places in the Midwest, we are seeing quite a few cases of COVID that are very similar to the numbers that we were seeing in January here. That being said, the main variant that has taken over pretty much is the one that is from Great Britain, from the United Kingdom. And that variant is concerning because it is a bit more contagious than the first variants we were seeing. It is still susceptible, however, to the vaccines that we have on market. And so it is of paramount importance for us to continue to do the same things we've been doing, which includes wearing a mask, washing our hands, keeping good hygiene. We had our lowest flu season in several decades as a result of some of the things that we've been doing. And so we need to continue to do those things to try to get to the point of reaching herd immunity, also known as population level immunity. So herd immunity really, it has a lot of different definitions that people use, but really to boil it down to its brass tacks is what, when a significant portion of the society has built up an immunity so that we don't pass it from person to person. That's just a boilerplate definition of what herd immunity is. And roughly, it really depends on how contagious the disease is. And so, for example, the measles is considered to be probably the most contagious disease in modern day that we have seen. It was contagious at a rate of about 95%. And so it took about 95% of the population becoming immune to it before we could consider to have herd immunity. For something like COVID, we're looking at a number, I've seen anywhere from 60 to 80%, and I'm a pretty conservative person, so I'm gonna rest right at 80% for what herd immunity we need to achieve. So that means 80% of the population here in the United States will have been either vaccinated or have some other form of strong immunity to the COVID virus. And so when we look at the vaccines that are out on market, the ones that have been approved for emergency use are the ones from Pfizer BioNTech, from Moderna, and from Johnson & Johnson. These are the three vaccines that are currently on market that have been granted emergency use by the FDA for use in terms of vaccinations. The Moderna and Pfizer both work very similarly. They are shots that are given in 2 doses. So you get 1 dose and then you get another dose. With Pfizer, it is about 3 to 4 weeks after. For Moderna, it is about 4 to 5 weeks afterward. So you get 2 doses of these particular vaccines, and they are delivered through what's called mRNA, which very simply is just the blueprint that the body gets to recognize a particular virus. They don't even give the whole of the virus's proteins, the whole of the virus's blueprint. They basically give you the blueprint for the lock and key mechanism that enters the cells. So this mRNA has been found to be 100% effective in reducing death and hospitalizations, and has been very, very significant in reducing even transmissibility of the virus. The Johnson & Johnson vaccine is delivered in a more traditional fashion. It is actually delivered through what we call an adenovirus, a deactivated adenovirus. So this is a virus that is not in the same family as the coronaviruses, but contains some of the proteins that the body would recognize from coronavirus. We are all aware that there has been some news about some of the recipients of the Johnson & Johnson vaccine. Right now, the number, as I can recall, is 7 individuals. I'm not sure if that number has increased from the last I checked. 7 individuals had a reaction to that particular vaccine. We can substantiate it was the vaccine that caused it. They had blood clotting that formed in one of the draining veins of the brain, as well as other areas of the body. This is a pretty rare form of clotting in that it did not respond to the normal things that we use to reduce clots in the body, like heparin. As a matter of fact, it was found that heparin might actually make it worse. As a result, they did pull the Johnson & Johnson temporarily, and they found that the commonality between those that had the bad reaction, out of the 7 million that received the vaccination, the 7 people who had bad reactions were all young females of childbearing age. And as such, they've done a bit of work in terms of thinking about what can cause it, and they have resumed the administration of the Johnson & Johnson vaccine. And we can, I'm sure I'll get questions about that later that we can talk about. But as far as how we make the decision about who gets what vaccine, generally the Moderna and the Pfizer were the first to be approved. And so as such, most of the places decided, most of the health departments and people who were administering the vaccines decided that it was in everybody's best interest to go ahead and roll out the vaccines to the population as quickly as we could. And so as such, most of the Moderna and Pfizer were mostly in distribution. The Johnson & Johnson had a lot of promise because it is one shot, one time, one shot. And so for people who are likely to be lost to follow up, who may not be, you may have them captured for one moment, and then you might not be able to get them again. The Johnson & Johnson is ideal. For those that have very busy lifestyles, are traveling very frequently. Again, a one shot was something that would be considered to be ideal. Also, people who are homebound, people who are in nursing facilities, all of those people were thought to be ideal for the Johnson & Johnson vaccine. I'm not sure, at this point in time, the numbers that were released are very low numbers. And really and truly, a lot of work was done in terms of looking at it. So the decision to go back to giving the Johnson & Johnson vaccine seems to be rooted in pretty sound science, based on everything that I've seen from the CDC, et cetera. But I really want to encourage everybody. I want to piggyback on President Sweetlove's message to really come to your own conclusion about the different vaccines that are out here, but listen to the experts, listen to the people who have had experience with it, listen to the people in your community and who you love, who have been exposed to both the illness itself, as well as getting the vaccine, and really come to a decision about looking out for the best interest of the community as a whole. One of the messages that I really try to send out to my patient population is that it's not just about you and your health, but the health of others around you. And so thinking of the others around you and getting to a point where we can, today it was just announced, our colleague on the Board of Health, Dr. Jahanger, announced on the news today that, we're going to basically remove almost all of the other restrictions except for the mask mandate, which is incredible if you think about where we were at this point, not even 4 months ago where we were. We really have made significant progress. And people who have had the vaccines can attest to the fact that, there's a sense of safety and a sense of almost like a weight is off your shoulder in some senses, because we're getting closer to what would resemble our old reality. I think some of the things that we have experienced, we're going to continue to hold on to. But at the end of the day, I think that we're getting much, much closer to seeing the light at the end of the tunnel than we were. And with that, I don't have any further initial remarks. I'm glad to take whatever initial questions you have, Ms. Franklin.
Great. We do have some questions in the chat, and we're going to encourage others to please put your questions in the chat, because this is the time for us to hear from our experts. But before we turn to the chat, I am going to ask you a follow-up question, Dr. Smith. You mentioned herd immunity, and I've heard on the news, on the national news, the United States needs to get to herd immunity. I've heard that internationally we need to get to herd immunity. But sometimes it's easier to sort of focus on what's in our own backyard. So What does it mean if a particular county has herd immunity, but maybe surrounding counties don't? How should we make heads or tails about herd immunity in those different populations that I mentioned?
That's an excellent question. And I think a lot of people are using that approach actually to eventually reach herd immunity. So what it's commonly referred to as community level immunity. And we, the rollout of the vaccine in the United States and in other locations has not been uniform. And so there are pockets of people and there are pockets of places where people have increased immunity and where there's absolutely no immunity at all. And as such, those places where there's no immunity still run the risk of overrunning the places that do have immunity. And what makes it even more insidious is that the people in the communities that are that have vaccinations, that have immunity, may still potentially carry the virus, and as such could potentially infect the people from outside of their particular pocket community. So I really wanted to use the example of Israel. Israel is one of the countries that actually has, for all intents and purposes, reached herd immunity. In Israel, their population is only 9 million, but in Israel, they have reached herd immunity to the point where people are able to go out essentially about their normal businesses. Businesses open, people don't have masks on, and they're communicating with one another, and their cases are extremely low in Israel. The Great Britain, United Kingdom, is also pretty close to reaching herd immunity, and that's an example of a place where it's not been so great. There still have been some pockets of outbreaks in the United Kingdom. So I think we're to speak to your point, we need to the pockets of communities need to try their very best to reach herd immunity within themselves before going out and circulating through the rest of the population. And I think that it helps that large cities like Nashville, Nashville's vaccination record is among the highest in the state, and it helps to have those large populations inoculated. But we really won't be doing ourselves a service if we don't reach out to our neighbors in the rural communities and understand their concerns and try to see about getting them to the point where we are in the city. I hope I answered that question pretty well.
Yes, you did. Thank you.
All right.
Okay, so I'm turning to the questions in the chat, and Jacqueline and Daphne are both helping me behind the scenes.
So,
But Dr. Alcindor, we have a question for you. Why is it that it seems in most cases that convalescent plasma was used as a last resort? Should it be used immediately once you have been admitted?
So when we think about virus replication and pathobiology in a person that has COVID-19 disease, it's very clear that early intervention, when virus replication seems to drive pathobiology, it would be most beneficial to come in with convalescent plasma at that time. If the lungs get to the point where they are beyond damage to where you need mechanical ventilation, the damage that the virus has done is already in place. And the idea of coming in with convalescent plasma at that time would be less effective. So when you think about being able to prevent somebody from going into the hospital, you would want to give them convalescent plasma prior to them having severe disease. And so the idea is that if you come in early, you're able to somehow reduce what we call virus load. And if you reduce virus load, you're likely to reduce the inflammation hurricane that this virus produces. And if you're able to reduce the inflammation, you're able to reduce the amount of damage to the alveoli, which are responsible for air exchange in the body. And if you can do that, then you can probably save that patient a trip to the ICU where they would be put on mechanical ventilation. And I wish I had some slides to show you this, but that's when you're in a fight for your life. And the idea is that the longer you stay under mechanical ventilation, the more likely you will not survive this infection.
Great, thank you. Dr. Smith, for you, I'm wondering if you could talk about how long the vaccines that we have will be effective. I heard that with Pfizer, we might need a booster within a year. How should we be thinking about that with all 3 vaccines?
Yeah, that's a great question because a lot of it is going to hinge on how quickly we can reach that herd immunity that we talked about. Assuming that we don't reach herd immunity, it looks like the best protection from the virus is going to last about 9 months. Most of the estimates that I've seen in studies from JAMA, from the Journal for American Medical Association, from the New England Journal of Medicine are showing that it's about 9 months of immunity. some of the more liberal estimates are looking at 12 months, and some of the more conservative estimates looking at about 6 months. I'm almost always firmly in the middle, and I tend to think that about 9 months or so is when the immunity will start to wane to the point where you would need a booster shot. Again, from a lot of the research that has been done and follow up on the vaccines, it looks like when they do give the boosters, it looks like it's going to be a single shot as opposed to 2 shots, based on what I've been hearing and reading. But it looks like about 9 months.
And so does that mean that we'll have to get, I mean, how should we be thinking about the shot, or do you think it'll eventually we'll have to get an annual COVID vaccine shot like we do the flu shot every year?
I sincerely hope not, but it looks like, at least for the time being, based on these projections, for the variants that we're seeing and how much they vary from one another, which is really not much, it looks like we'll need at least 1 round. I really, based on the knowledge that I have from the people that I trust and from what I've read, I can't perceive this particular virus lasting more than the natural course of it, even lasting more than about 5 years. That's a natural course. So, with us using a vaccine, and this is just, again, based on information I've talked to other people who I trust about this, it looks like we probably, if we reach herd immunity, or are getting close to reaching herd immunity, it looks like 1 round of boosters might do it.
All right, thank you. Dr. Alessandro, I'm wondering if you could talk to us a little bit about the informed consent process for a person that might be faced with making an in-the-moment decision about whether to participate in the Pass It On clinical trial.
So this is strictly voluntary to start with. And because it's voluntary, you have to then volunteer, and then you're evaluated for your eligibility. And then once you're eligible, then you have to consent. And this is a standard consent. And that means reading the consent form from the study team and signing that consent form. And when that all happens, then you would be considered in the trial, unless there's something that goes wrong where you become ineligible for the trial in some way, meaning that you may develop some type of an illness during your eligibility phase that would disqualify you from being part of the trial.
And I do have another question for you, Dr.
Sure.
Alessandro. Is the convalescent plasma the same as the monoclonal antibody treatments? If not, how does this differ?
It is not. And so the convalescent plasma would be all the antibodies that a person has, including those that are specific to the virus, you see? Now, the monoclonal antibodies are antibodies that are generated in the laboratory, and they are to specific components of the virus that are responsible for neutralizing the virus. And I say neutralize, I mean bind to the receptor or a component that would prevent the virus from entering a cell to establish the infection. So monoclonal antibodies would be very specific, and convalescent plasma that contain the antibodies would be antibodies on a global scale. So you would get not only antibodies to the virus, but other antibodies that person would have as well.
All right, great. Thank you. Dr. Smith, I have several questions in front of me. And the one I want to ask you about the vaccine passport. I know that when I received my vaccine, I received a little card, and I have it with me in my purse. Not sure how to keep track, but how should we be thinking about how to prove whether or not we've received the vaccine? What do you think is coming down the pike with regards to a type of passport?
Sure. So I think for me personally, I carry my card with my passport. I do it for that reason because, number one, I'm not really using my passport a whole lot, but it's a very important document for me. And I know where it is at all times. So if I need to pull it out and use it, I can. But I'm not carrying it with me like I do my driver's license, for instance. there were many people who, after they got their initial vaccines, were very excited about it and laminated them. I don't really suggest doing that because of the fact that, again, we're considering possibly having to do the booster shots here. And so ideally, they left spaces there for people to be able to put further vaccinations on that card, just in case. They can probably still put the stickers onto a laminated version of the card. But I think that what we're going to be dealing with eventually is, like, if you're wanting to travel, if you're wanting to go to a large group gathering, like a football game or a sporting event, concert, something along those lines. If we get to that point where they decide that vaccinated individuals can gather in large gatherings, that's probably going to be the best use of that passport, the vaccine passport. And so, what I suggest to everybody is keep it in a safe place where you can easily access it, and to anticipate being able to use it for travel and large events.
And a follow-up to that, a question came in a couple minutes ago. If we have to have a booster, which it sounds like we may have to have one, do you think that it could possibly be another form outside of a shot, like, for instance, a nasal spray or something of that nature?
I'm not sure if a whole lot of scientific effort has been put forth to try to get a nasal spray. I know that the certainly from the idea of administering it, it would alleviate a lot of the fears that a lot of people have. But as to the delivery forms and how it is delivered to the cells in the body, I don't think that practically it's reached that point as yet. I think we're probably still going to be looking at injections, and especially because of how the mediums and things like that keep the mRNA. Remember that the mRNA vaccines that we were giving we are giving have to be kept at a colder level than a lot of the vaccines previously. And so that probably has an effect as well on whether we can administer it through a nasal spray or not. Okay,
great. Thank you. So how do we, Dr. Smith, this question is for Dr. Alcindor. How do we help with the convalescent plasma research study if we've never contracted the virus, or if we haven't been vaccinated? And I think my follow-up question to that, if you have been vaccinated, does that mean that you can, that your plasma could be eligible to help someone else?
So so you can help by going to the website, passitOnstudy.org, and then you can find out more about the trial. And then you can pass this information on to friends, families, and particular people that have had COVID, recently come out of the hospital, or may still be in the hospital, that are likely to want to participate. And so there's a lot of information. You can put this out on social media to tell people that you think are not aware of convalescent plasma. You can put this out in terms of group meetings that you have at work about convalescent plasma. But again, those people that that have had COVID recently in the hospital and so forth, the idea of contacting their family members and letting them know that they can be a possible candidate to participate in this trial is very important. Because you can think about it this way. There are a number of stories in the Pass It On library that shows women that get together and men that get together after receiving convalescent plasma and saving the life of another person. And so the idea is that the power of convalescent plasma is the power of giving of yourself for somebody else. And in doing that, you can save a life. And I think that's very important. And so now, a person that has received the vaccine, again, you would expect that this would be a person that is going to have a level of immunity. However, it would take some time to develop the level of immunity that's required. What they want primarily are those that have recently recovered from COVID-19 and have antibodies and are willing to be bled for those, bled to get plasma to administer to other people. The idea is that if you have recently been vaccinated and you want to be evaluated for participating in this convalescent plasma trial, you can call the number, you can go to the website, and you can ask them the criteria by which you would be eligible. I want to also say that convalescent plasma has to be at a particular titer. And when we say titer, we're talking about concentration of antibodies that would make it useful as a intervention. So the titer of convalescent plasma is important. It basically says the concentration of the strength. That means if you waited too long, or you're sitting there after infection or vaccination too early, you might not be eligible to donate.
I really appreciate the clarity in which you're providing your answers. I'm learning a lot today on the call, so thank you, Dr. Alcindor. Okay, so let me ask you, Dr. Smith, a question regarding vaccination sites. So over the weekend, I volunteered at the Islamic Center of Tennessee, where we had probably about 350 people come through to get their vaccine. Most of those individuals received their second shot that day, but some received their first shot. And so we handed them a flyer saying, you need to go elsewhere to get your second shot. So that was the first time we did that. So I'm asking you a couple of questions wrapped up in one. One, if you received one vaccine, for example, Pfizer, does your second shot have to be Pfizer? Or if you received both doses of one vaccine and you get a booster down the line, does that still have to be the same brand? And then I'll ask you a follow-up question after you answer that one.
Sure, that's an excellent question. So what we know about, there are trials currently going on where they are mixing and matching vaccines. Okay, what they found so far is inherently it's safe. So that's usually the biggest priority, is whether it is safe or not to mix them up. And so the answer to that particular question is yes, it's safe from what we know so far. If you got in Pfizer and get a Moderna or vice versa, it's safe. Now, whether it is effective is still to be seen. The evidence is leaning towards yes, it is safe and effective. So and they already kind of have a caveat in terms of the administration of the vaccines that say, in an emergency, people can mix. So I think that the theory and the science is that it probably is safe. It probably is effective, but it has not been fully studied yet. So my answer to that would be to try your best through the Vaccine Finder website, which has been posted a couple times in our chat here, as well as using Google searches, et cetera, to try to find a location that has the similar vaccine to what you received previously. But in a pinch, and in a worry, I wouldn't worry too much about mixing it. I think it should be safe, especially if you're staying within Pfizer and Moderna, which are delivered in the same way, the mRNA vaccine. As to whether you can get a Johnson & Johnson or, whether the booster, like if you get Johnson & Johnson and then want to do a Pfizer, a Moderna booster, I really can't speak to how effective those would be, other than to say that just one shot, even for those that just get one shot, you still have increased your immunity to about 60% just from that first shot. So people should feel, I don't want to make people complacent in saying that, but I do want them to feel that they don't need to stress themselves out to the point where they feel as though they're in danger by mixing and matching. Did that answer what you were asking?
That did. So thank you. And also in terms of feeling stressed out, if they say in 21 days or 28 days you have to be back, is there usually some leeway time?
There's absolutely some leeway. There's absolutely some leeway. So and I want to speak real quickly to just kind of the sentiment in general, because we as the Black community take a lot of flack sometimes unnecessarily about how we feel about the vaccine. And I want to reassure some people with some numbers. So first and foremost, the Black community is responding very, very well to vaccinations. one thing that has to be said, and I think that physicians have to learn, is that we have to be able to talk to people about their concerns and listen to them. Listen to what people say, because the concerns people have are legitimate. When people don't trust, they've been given a reason not to trust. So we have to address that head on. We have to allow people to express how they feel and to present them with evidence, based on what you know, and allow people to have some time to process. This is an urgent situation that we're in. And, I understand that we really want all of our friends and family to do as we say and do as we do. But, especially I've had to learn, even as a physician during this period of time, to have some grace with my friends and colleagues and everybody else about their processing and coming to a good solution here. And I think, when people are able to see things, they are able to believe a lot better. Unfortunately, sometimes people have to experience things too sometimes. We hope that that's not the case. But I say all that to say that, in terms of, and I know I went all around the initial question you asked, Ms. Franklin, but I want people to understand that it's okay to have some questions and to have your questions answered. And if your primary care doctor doesn't take that time to answer those questions, and that offers you an opportunity to really feel as though you need to reevaluate that relationship with that primary care doctor, because this is a time where we need to understand, and your primary care doctor needs to understand who they are treating and the history. Again, we're not gaslighting people. Things occurred in the past that were horrid, unsavory, and wholly unethical. And we can't act like those things didn't happen, but we can also let people know and reassure them that on this particular instance, we've had people to advocate for, fight for, and sit at the tables and monitor and protect the people that look like us.
Thank you. Dr. Alcindor, I was wondering if you want to respond to the last few minutes of the conversation as well.
Yeah, so I had a few things about the nasal spray. And so when you think about nasal spray, you have to think about mucosal administration of a vaccine. And so for that to happen, you have to have another clinical trial. You see what I'm saying? You have to basically go through a clinical trial and show that nasal spray will effectively lead to an infection that will produce an immune response that's appropriate. And so a nasal spray simply means more research to be done. I want to say a little bit about this herd immunity, okay? And so I agree with everything Dr. Smith said. One of the things about herd immunity is the concerns I have. And the concerns I have is this. We know that children that are under 17 years old, under 16 years old, they represent about 20 to 25% of our population. They don't have a vaccine right now. And so we're basically starting with 80% of our population when you take out these children. We are right at the level of what herd immunity is if we think it's 80%. So we're starting there saying we would have to vaccinate all adults 16 to whatever in order to reach herd immunity. We have got to get together and vaccinate these children to bring us close. Now, there was something that Dr. Smith talked about that I am very well acquainted with, and that is I've been boots on the ground in the Nashville neighborhoods talking to people about vaccine hesitancy. This is very real. And so I get everything from why are you coming in here with this poison to kill our people, to yes, we understand this, we want your flyer and we want to participate. Tell us what we can do more. And so it is a mixed bag. And then when you go into Latinx communities, you have a situation that's somewhat different there. You're talking about people that are basically paralyzed with fear because they come from mixed generational households where some of them are non-documented. And they are simply not ready to go and register with their name and address, and because they think that immigration officers are waiting for them at vaccine stations, and they're just not ready to participate. Again, I agree with Dr. Smith in terms of meeting people where they are and giving them information that they understand in a culturally context manner. You will meet people that don't know a word of English and they need to be vaccinated. And that's why Mahari has stepped forward. And I want to say something about what Meharry has done so far. And that includes Dr. Smith's team. And that is, you can't give them enough praise for what they've done. And that is, they have come out and been on the forefront of delivering vaccine, I'm sorry about testing across Nashville at 3 different testing centers. And they have been doing this from the beginning. Rain or shine, they are out there testing people. And again, 3-day return on that test and probably getting lower. And so all I'm saying is that Meharry has done quite a bit. And let's not talk about Meharry's involvement with Novavax, which is a new vaccine that you don't know anything about right now, but you will very shortly. So Meharry has been participating in a vaccine trial here with Novavax, another vaccine that represents basically a fermented protein and an adjuvant mixed together to give you as a vaccine. The Novavax numbers are very similar to Pfizer and Moderna. It is making a name for itself, and it will be up for emergency use authorization relatively soon, within a matter of weeks. It could basically solve the bottleneck that we're in with the Johnson & Johnson vaccine. And so the idea is that Novavax might be that vaccine from a very small company that has never delivered an FDA-approved drug, could be the solution in a lot of ways. To get us to the numbers that we need, Novavax might be there for us in that regard, if it can deliver what it's saying it's going to do. And of course, Johnson & Johnson was a very important vaccine, and it still is. And I did not expect it to be on pause very long. And the reason being is that a 1-dose vaccine for people that are migrating here and there and not going to come back for the 2nd dose, and a vaccine that you can put in your refrigerator at home. And at the same time, Johnson & Johnson has basically said, we're going to give this vaccine free to people that need it, because we are simply not a United States population. We are a global population. We have to vaccinate the world in order to keep this monster off of our shores. We know because of commercial trade and human travel, these viruses will come to our shore no matter what. The idea of trying to say we're going to have travel restrictions, we know better than that. Viruses can get past travel restrictions. You see what I'm saying? And of course, what we have to be concerned about is breakthrough infections. I don't know if you know what that is, but breakthrough infections are in people that have been immunized with both doses will come down with this infection again. So in a study done 77 million people, they saw 5,800 breakthrough infections. And the idea, if you start looking deep down about these breakthrough infections, you see many of them are associated with the new variants. And so these variants are going to be important going forward, and we have to be mindful that they are important. And the idea is that we are starting to see something very interesting coming out of India. We are seeing hypermutations, that is triple mutations within a variant, a single variant. And I predicted that this would happen because if you have a situation where a person is infected, what we call dual infection by multiple viruses at the same time, the possibility of having hypermutations for variants is very real. And so the way to not think about these variants is to get up off your couch and go get vaccinated.
Okay, so thank you for taking me back to graduate school. But you know, and you did a much better job than my professors at breaking this down. And thank you for wrapping up with that take-home message: go get vaccinated. We have a few more questions that we want to get to. So please, if you have more questions, drop them in the queue and question and answer portal. But Ms. Beulah Oldham has a couple of questions. So I'm going to try to merge the two of them. So vaccination sites, well, for instance, here in Nashville, Tennessee, Music City Center is closing as the mass vaccination site. But I do know that the health department is going to churches and community centers and going to places in the community to administer the vaccine.
Mhm.
So as these larger sites start to close down, will pharmacies continue to offer? Will they be free, or will we have to pay for a copay if we go to our doctor's office to get them? So for instance, I might go to Meharry or Vanderbilt because they're saying you can come in to get the vaccine. Will I have to pay copay or will it be free? And how should we think about pharmacies and all of this? And then I'm going to come to you all with a question about young people.
Okay.
So I'll let either one of you take that.
Right now, you know, Meharry for certain is still giving the vaccine for free. And I don't know of any plans going forward anytime soon. And Dr. Alcindor may be privy to something that I don't know. But I don't know of any plans right now to monetize it, to start to charge for the vaccine in the near future for Meharry. I also know that the clinic at Metro General Hospital on Fridays is still offering it for free. And I do not know of any plans again to monetize that in the near future. The future, though, does, I mean, to your point, as we know from the history of pharmaceuticals, eventually people will pay the piper for the research that has been done. They received a lot of money from the government as well. And let's not forget that. The government did supplement quite a bit of the research that was done for these vaccines. But eventually, I do see it going onto the free market and having a copay associated with it, not unlike what occurs for flu vaccines, et cetera. But because it is still a public health emergency, I think that's driving a lot of what is going on. But I welcome, and as a matter of fact, Dr. Alcindor, again, I need Dr. Alcindor in my clinic as well for the way that he explains, because he has a gift for doing it. I want to just say one quick thing really quickly to give some credit to my other colleagues at Meharry, because I stopped participating in the testing sites early in when I had to come back to my school teaching. So I wanted to give the credit to Dr. Julie Gray, to Dr. to Amber, and to all of those at Meharry who kept going with that, because they really were the ones to keep that site up and running. But I defer to you, Dr. Alcindor.
Yeah. So all I want to say, I agree with Dr. Smith said. And what I want to say is that if you're going to places like Kroger, they're also asking you to use your insurance card if you have one. And what they're saying is this is an administration fee from Kroger for you to get that vaccine. So in some ways, there's some kind of commercial exchange for this vaccine. The other thing I wanted to say is that you'll probably start seeing fees being charged when this vaccine gets full approval. And there's some of them that are going to probably be looking at that very shortly. And the thing about that's driving that is going back to school. And I don't know if you know, but there's a number of colleges that are saying to come back to school, you have to have that vaccine card. And the idea is this: they're saying we won't maybe require this until one of these vaccines become fully approved. Emergency use authorization is simply not full approval. And so what you're going to see, more than likely, Pfizer and Moderna basically going to get full approval. When you get full approval of a vaccine, you get licensure. When you get licensure of a vaccine, now it's for sale, just like anything else in the store. And what you're going to realize is how expensive these vaccines can really be once the government oversight is withdrawn. These vaccines are not going to be cheap. Remember, vaccines in general that we have used for many years have been in a range of $4 or $5 a dose. You simply will not get Moderna and Pfizer vaccines for that kind of money. I want to say one thing about vaccines that I have to say before I leave this program tonight, and that is the safety of vaccines. Let me just say one thing. In 1960, we had 5 vaccines that were available to us in the United States: polio, smallpox, diphtheria, pertussis, and tetanus. 5 vaccines in 1960. That's it. In 1983, we had 24 vaccines, but something happened in 1986. The National Child Vaccine Injury Act was passed, where the idea then is that you could not claim injury to vaccines That is children, their parents, and so forth. That increased the vaccine schedule in ways we have never seen before. From a baby that's born today, as of 2019, and when that baby reaches 18 years old, they will have received 74 vaccines as stated by the CDC. Many of them will be influenza vaccine, but 74 as opposed to 5 in 1960. Vaccines, when you think about it, I talk to mothers that are out there. I say, how many of you have school children? All of them tell me they do. And I say, how many of these children go to school? They have to have vaccines every year, and their vaccines have to be updated. So they have been receiving vaccines for decades, these children. And I asked the mothers, how many of these children have had adverse events associated with all of these vaccines they've received? And I hear nothing. And the reason I hear nothing is that vaccines in general are the most scrutinized and regulated medical interventions for public health that we have ever seen. And they have been safe for decades. And I want to say that vaccines has allowed us to live 30 years more than we did 100 years ago. And so the idea is that when you think about vaccines and what they've done, you would have to give back all these children that would have died of measles, polio, mumps, rubella, and so forth. Vaccines have taken childhood diseases and death away. Polio and smallpox are no longer with us in a serious way. We have come to a point with mumps and measles that we have had eradication status for measles. However, what we saw in 2019 is a prelude to what we can see with COVID-19. And that is this: when a Jewish community in Brooklyn, New York decided not to vaccinate their children for measles, what they saw as a pocket of measles developing in that community. And the idea was, it was misinformation because there was some people going around saying that there were pork products in the vaccine. And that made Jewish individuals nervous about giving their children vaccinations. At that time, there were thousands of children with measles coming from that particular location and spreading. And so all I'm saying is that without a vaccine, we can light a stick of dynamite in some of these neighborhoods that's going to blow up. And we're going to have pockets of people that are resisting these vaccines that will allow this virus to replicate. And we will have the continual emergence of these variants to the point where we will get a variant that our immune system to these vaccines will not be able to deal with. It is a great concern to me. And again, I stress, we are a global community. And when you think about vaccine inequity, I think that this is something that's shameful. When you see a country like Canada with 38 million citizens sitting on 100 million doses of vaccine, and a country like Nigeria with 220 million citizens that have little to no access to vaccines, what are we going to do about this? And so the idea is that we have to see ourselves through the developing world because we are a global community.
I wanted to take, we're coming to the bottom of the session. And I do want to get two more questions in before I turn it over to President Sweetlove for the final word, and also Daphne. The question that I wanted to ask was about young people, particularly 12 to 15. I have a daughter who will be 14 in a few days, and she's been out of school most of the year. Now she's back in the classroom, but she was isolated. My youngest is still at home and hasn't been able to play with her friends. So Dr. Smith, I'm wondering if you could sort of talk to us about students and how we should think about vaccines for that age group, both 12 to 15, when they might be online, and then also under the age of 12, and the benefit of getting kids back in the classroom.
Sure. So as far as children ages 15 through 12, Pfizer has already submitted their data. and it has shown very similar rates of safety and efficacy to the version that is given to adults. And so they have already submitted for approval for emergency use authorization. So I would anticipate that that would be on the horizon in the probably next couple of weeks for those 12 to 15. Now, for those younger than that, they're still looking at what's going on. And you have to remember, younger than the age of 12, their immune systems are quite different than the immune systems of adults. They are still, they're so naive to so many of the things that we see in the environment, that their immune systems are essentially still in college. That's the best way. That's the way it was taught to me in my immunology courses at Meharry. So their immune systems are still learning and still growing. So it would require a little bit more research and thought for those groups, those less than 12, but certainly those between 12 and 15, and that's a crucial age, as you indicated. They have a lot of social interactions, and they represent a lot of movement in society as a whole. So that group is crucial, and it looks like they're going to be approved here pretty soon.
I just want to say a little bit about that. So I agree with what Dr. Smith said with that particular group. And again, you're probably looking at them beginning vaccinations with the Pfizer vaccine probably before the summer is over. And so this is going to be very important coming into September for the new school year. I want to say something about what Meharry is doing with the 6 months to 11 years old. So Meharry is working with Moderna Therapeutics to try and develop the doses that are needed of their particular vaccine through a vaccine trial. And this is going to be dosage related. And again, they want to find out what kind of dose is going to be needed to deal with a 6-month-old versus a 5-year-old versus an 11-year-old. And so Meharry is working and is going to be a part of this. This is a multi-center trial to start looking at those individuals. And of course, it's going to take a while for this is done. But again, when this is done, the numbers will be out, and you're going to start to see people get vaccinated. One thing I want to say is this: for a mother, and we thought about this because pediatric vaccines are, especially with this particular disease, has been very politicized. And so for a mother to say, I'm going to give my 6-month-old to you to vaccinate with a vaccine that is controversial like this one is going to be difficult. But at Meharry, what we have come to understand, and I'm a part of that vaccine team, we're saying to those mothers, we're saying, you have had your baby at our hospital. You have trusted us with your baby. And the idea is that we want you to go one step further and trust us with the health and wellness of your baby for this vaccine. And that's the way we're going to approach that initiative.
Thank you. And then the last question comes from Sonia Eskridge around chemotherapy. So I actually was under chemotherapy treatment recently, and my personal experience, my oncologist said, Tanae, get the vaccine as soon as you're able to do so. I trusted my oncologist, but for other individuals and family members that have loved ones that are undergoing chemotherapy treatments, what advice would you give them regarding the vaccine? And I'll just open it up to and let both of you answer that question. Go ahead,
the MD talk first here.
Thank you, Dr. Alcindor. So for me, what I'm advising my patients who are undergoing chemotherapy to much in the same vein as what was told to you is to go ahead and get it as soon as you possibly can. You have to keep in mind, for those that are receiving chemotherapy, that some chemotherapies, most chemotherapies, as a matter of fact, affect the cell lines that can help with immunity. So if you have just recently received chemotherapy and at your nadir, the vaccines may not be very effective for you. I just based on the mRNA ones, from what I know, they still would be relatively safe from what I can understand, but they just wouldn't have the same strength and effect that you would want. So based on that, I obviously defer to my colleagues in oncology, but I listen to them as well. And, I know a part of my job in being a primary care doctor with patients that are seeing oncologists concurrently is to know what to expect what they're going to hear from them. And so I say, yes, as soon as you possibly can, as long as you're not like in that immediate 2-week period after your chemotherapy session, I would say it'd be safe and certainly to go ahead and do it. Dr. Alcindor, what do you know about it?
So I agree with what Dr. Smith said wholeheartedly. And the idea is that if you're undergoing chemotherapy, depending on what it is, your immune system is going to be disrupted. That's for sure, because most chemotherapy is used to fight against cells that are growing rapidly. And the idea is that cells that are turned over rapidly can be affected by different types of chemotherapy. I say this to those individuals that also have autoimmune disease that would be in a similar class. And again, all indications from the CDC says that you need to get this vaccination. And the reason being is that to get straight out COVID-19 with these conditions, you're going to have severe disease, more than likely hospitalized and at greater risk of dying. And the idea is that it goes along with women that are pregnant and lactating. Again, the CDC is saying, talk to your physician, talk to Dr. Smith about it. But again, they are urging there is no restriction for you getting this vaccine if you're pregnant and lactating. Again, pregnant women are at the risk of more severe disease when they get COVID-19. And the idea is that they should protect themselves. But Pfizer or Moderna, there seems to be no restriction for pregnant and lactating women, just because, again, if you get this disease without the vaccine, the complications are much worse.
I can't thank you both enough for spending your evening with us. I have learned immense amounts, and I thought I knew a lot about the vaccine, and I think I do, but I have learned so much more. And so thank you both. Jacqueline, as we close up, I'm wondering if you could just drop the information about the Pass It On trial again in the chat, and also the vaccine finder. Dr. Calvin Smith, Meharry Medical College, Dr. Donald Alcindor, Meharry Medical College, thank you for the knowledge you imparted on us this evening. President Sweetlove, I'm going to turn it over to you for the final words.
Thank you so much. Again, thank you to my amazing health team, Tanae and Jackie. They always do a fantabulous job. And you doctors from Meharry, you guys, I always knew Meharry was just over the top, but you guys have just been so wonderful. The information that you shared, I wish I could bottle it and go sprinkle it all over the community. But what we'll hope to do is have you on at another time. We'll hope to share the YouTube with some of everybody. You guys have been great. Thanks a million. If there's any little thing that Tennessee State Conference can do, please don't fail to let us know. Hey, we're boots on the ground even during this time. We'll put our masks on and go walk where you need us to walk. Thank you so very much. At this time, Daphne is going to come with some announcements, and we will be finished up.